Sore throat refers to any painful sensation localized to the pharynx or the surrounding anatomy. The developmental ability of the young children to identify and define their symptoms varies, and the pediatricians must pay careful attention to the patient and the caretaker in order to clarify the exact nature of the complaint. Now, sore throat can be the symptom of a disease process that does not directly affect the pharynx. Occasionally, young patients with dysphagia, which means difficulty in swallowing, that results from disease in the area of the esophagus or with difficulty swallowing because of a neuromuscular condition, may verbalize these sensations as a sore throat, or their symptoms may be interpreted by a caretaker as a sore throat. Now let's talk about some of the common causes of sore throat. The first and the foremost is viral pharyngitis. Now, infection is the most common cause of sore throat, and the etiological agents are usually respiratory viruses, of which a few cause are readily identifiable syndromes, including number one, for example, adenoviruses. Now, adenoviruses cause pharyngoconjunctival fever, in which there is a benign follicular conjunctivitis, red eyes, often accompanied by febrile pharyngitis and cervical adenitis, which means that the pharynx would be red, inflamed, and there are enlarged cervical lymph nodes. The other one is Coxsackie viruses, especially the Coxsackie A viruses. Now, Coxsackie A viruses, they cause herpangina, or if you take the other variant, that is known as the hand, foot, and mouth disease, in which there are lesions inside the mouth, on the hand, and on the feet. Then the third, herpes simplex virus. Now, herpes simplex virus, which causes cold sores, usually causes stomatitis, which is inflammation of the oral cavity. However, it may cause pharyngitis, especially in the immunocompromised child, and rarely in the immunocompetent child as well. Then coming down to the favorite these days, and that is the coronavirus 2019, which is known as COVID-19. Now, sore throat and pharyngeal erythema, or in other words, pharyngeal redness, it occurs almost in half of the symptomatic children who have got COVID-19 infection, especially those who are suffering from the latest Omicron variant. Now, fever and cough are the other common symptoms apart from sore throat, which is quite common in these kids. They can also have fatigue, nasal congestion, diarrhea, and vomiting, but those are less frequent in these kids. Then coming to the bacterial causes, and that is streptococcal pharyngitis. Now, viral etiologies are closely followed in frequency by the bacterial causes, especially the group A streptococcus, which is also known as Streptococcus pyogenes, which is the most frequent bacterial cause of infectious pharyngitis. In the winter months, during the streptococcal outbreaks, which are more common in winter months, as many as 30% of episodes of pharyngitis may be caused by this bacteria, which is known as Streptococcus pyogenes. The clinical manifestations, they include high fever, which can go up to 40-41 degrees Celsius. There are usually exudates on the tonsils and the pharynges, so that the tonsils would be quite red. They would be covered with some form of pus or exudate, which might be whitish or dirty whitish. They might also have hemorrhages on their hard palate, which is known as palatal petechia, which may also be there on the soft palate. And they might have tender anterior cervical lymph nodes. So the lymph nodes over here, they would be enlarged and they would be painful. Then another common cause of sore throat is what we call as infectious mononucleosis. Now, the agent in this particular case is the Epstein-Barr virus, which is also known as EBV. It mostly affects adolescents, but rarely infectious mononucleosis can cause, rarely, again, it's not that common, life-threatening airway obstruction from tonsillar hypertrophy. So usually these kids have got what feels as tonsillitis. They've got fever, they've got enlarged tonsils with exudates on them, but you would see that they do not respond to the antibiotic therapy. So even if you have given them 1 or 2 courses of antibiotics, they do not get better. Rather, they would come up in a rash. So if they are given, especially the penicillin group of antibiotics, in case of tonsillitis, and they come up in a rash, that is very much suggestive of infectious mononucleosis. Another additional consideration, especially in adolescents with an infectious mononucleosis-like syndrome, would be the human immunodeficiency virus, also known as HIV. Now, some other conditions that can cause sore throat, that include some unusual infections. Now, these include infection from Neisseria gonorrhoeae, Corynebacterium diphtheriae, Francisella tularensis, and some of the anaerobic bacteria. Now, in this, I would like to mention about Neisseria gonorrhoeae sore throat. Now, Neisseria gonorrhoeae, which causes gonorrhea, it may causes inflammation and exudate in the throat, but more often remains quiescent and is usually diagnosed only by culture. As far as tularemia goes, the oropharyngeal tularemia is quite rare, and it should be entertained only in endemic areas among children who have got exudative pharyngitis that cannot be categorized by standard diagnostic testing and persists despite having a good antibiotic therapy. So if a child belongs to an endemic area where tularemia is endemic and they have got tonsillitis-like features, you give them antibiotic, they do not get better, then, and the standard testing does not reveal any etiologic agents, then you should be thinking of oropharyngeal tularemia. Some of the other organisms includes the group C and group G streptococci. It also includes Mycoplasma pneumonia and Chlamydia pneumonia. Now, they have been implicated as agents of pharyngitis, especially in adolescents and adults. But as far as a childhood is concerned, their roles remain unproven and their frequency is frankly unknown. Then another category is irritative pharyngitis. Now, irritative pharyngitis, what happens? Drying of the pharynx. So if there is dryness of the pharynx, it may irritate the mucosa, leading to a complaint of sore throat. Now, this condition occurs most commonly during the winter months, particularly after a night's sleep in house with forced hot air heating. So people who have got like closed houses with a lot of, hot air heating going on at night time, that can cause the dryness of the air, and that can cause dryness of the oropharyngeal mucosa, and that can give an irritative pharyngitis, a sort of an irritation or soreness in the throat. Then rarely foreign bodies, a foreign object such as a fish bone, it may get embedded in the pharynx, especially who's eating fish, and that can also give them a sore throat. Herpetic stomatitis, as I told you earlier, herpes simplex, which mostly causes stomatitis, but and which is usually confined to the anterior buccal mucosa, can sometimes extend back and onto the tonsillar pillars. In these more extensive cases, the child may complain of a sore throat because the lesions have gone back and they are over the tonsils or over the posterior pharyngeal wall. Similarly, some of the systemic inflammatory conditions, they can also cause sore throat. So Kawasaki disease is one of them, which is characterized by high fever. You need to have fever for at least 5 days with at least 4 of the 5 following findings. So they should be having conjunctivitis, mucositis, that's inflammation of the mucosa, which usually contains redness or cracking of the lips and tongue, peripheral erythema or swelling of the feet and digits. It might be a truncal rash associated with that, and large cervical lymph nodes. Another condition that can also cause sore throat is Stevens-Johnson syndrome. Now, that is a disease of unknown etiology. We don't know what causes it, but it's a rash which is polymorphous in its characteristics, along with oral and ocular lesions. And it is presumed to be immune mediated, which is characterized by vesicular and ulcerative lesions of the mucosa, including the pharynx, the genitalia, and the conjunctiva. Additionally, children with this condition may have a diffuse rash, which often consists of target lesions of vesicles and bullae. It's usually self-limiting, but occasional cases may lead to dehydration or may progress to involve the pulmonary system as well. And sometimes it can be, which is quite rare, it can be fatal as well. Then another category is of referred pain. Now, sometimes pain from inflammation of the extrapharyngeal structures can, give a sensation of pain in the region of the pharynx, that actually feels like a sore throat. For example, dental abscesses, inflammation of cervical lymph nodes, or inflammation of the middle ear cavity that can give you a sensation of soreness in the throat, and that is the referred pain because of the shared nerve origins of this particular area. Now coming down to some of the life-threatening conditions which can cause sore throat, and one of them is epiglottitis. Now, epiglottitis, which is actually inflammation of the epiglottis, is a well-appreciated cause of life-threatening upper airway infection and obstruction. It has declined significantly since the introduction of the global Hib vaccination. However, the disease manifests with a toxic appearance, a very high-grade fever, stridor, and drooling. Sore throat usually occurs in many cases, but is rarely the only primary complaint, because there would be many other associated symptoms which would be, told by the patient. Then is retropharyngeal abscess. Now, retropharyngeal abscess can cause sore throat, and they usually occur in children less than 4 years of age. The other complaints along with the sore throat include neck pain and fever, and there might be difficulty swallowing because there is a bulge in the throat, and there might be respiratory distress as well. The posterior location of the abscess makes it difficult to visualize on physical examination. So it's better to get a X-ray lateral view of the neck, which would visualize the soft tissue swelling, and that is very much diagnostic of a retropharyngeal abscess. Then rarely lateral pharyngeal abscess. So this is not the retropharyngeal abscesses to the sides, like we call them as lateral pharyngeal abscesses. They produce symptoms similar to retropharyngeal infections, but the occurrence is less often. So high fever is common in them. Other signs include strabismus, like lockjaw, and there is a swelling below the mandible on the sides. Another important condition is peritonsillar abscess. A peritonsillar abscess may complicate a previously diagnosed infectious pharyngitis, or maybe the initial source of a child's discomfort. Now, this disease is most common in older children and adolescents. The diagnosis is evident from visual inspection, so you have to look inside the throat to diagnose this condition. It is usually augmented by careful palpation. So if you palpate the neck, you can feel that on one side is more swollen than the other. The abscess produces a bulge in the posterior aspect of the soft palate, causing the deviation of the uvula to the contralateral side. So if you are examining a child's throat and you see that the uvula is deviated to the other side, and one tonsil seems to be more enlarged than the other one, then your diagnosis is peritonsillar abscess. So these are some of the common causes. Some of them have been uncommon causes as well. One thing which I would like to mention here is diphtheria as well, though diphtheria is rarely encountered these days, more of a historical thing, but still, like, you might get 2 or 3 cases, per year, even in the developed world as well. So it's basically it can be life-threatening, but it's as I said, it's seldom encountered in infectious pharyngitis. Now, it is characterized by a thick pharyngeal membrane, so a sore throat with a thick pharyngeal membrane and very marked cervical lymph node enlargement. These days, because the kids are universally vaccinated against diphtheria, therefore it's very rarely seen. But anyhow, it can be sometimes be seen in unvaccinated kids or those who have got some immunocompromised condition. Then one thing that I would like to mention as a cause of sore throat, quite rare but quite serious, is Lemierre's syndrome. Remember Lemierre's syndrome? This is an unusual infection, and it is caused by anaerobic bacteria, especially the Fusobacterium nephrophorum, or sometimes it could be a mixed anaerobic flora. It is important to note this condition because it is associated with jugular venous thrombophlebitis. So the infection can spread and can cause thrombophlebitis of the jugular veins. And if there is infection of the jugular veins, then it can be complicated by septic emboli. So both children and adults with Lemierre's syndrome almost have pharyngitis at presentation, and it should be considered in all ill-appearing patients with neck pain who have got severe pharyngitis and respiratory distress and have not get better with the routine antibiotics, and they are looking very, very unwell or seriously ill, or if they've got painful bulging neck veins, which are an indication of thrombophlebitis of the jugular vein. So these are some of the common and uncommon causes of sore throat which you should keep in your differential diagnosis. Now, the most important thing when you take a history is that you also have to follow it with your examination. You have to examine the oral cavity and the throat. So remember, many things are visual. Like, for example, the thick membrane of diphtheria is something which can be seldomly missed if you know a child has been unvaccinated and has got a risk factors for diphtheria. Similarly, a child who has got, like I told you, has got like marked exudates, pus on their tonsils, and they've got cervical adenopathy, that is most probably a streptococcal pharyngitis, and they would need antibiotics. Now let's talk about algorithm which helps you in narrowing down the differential diagnosis of sore throat and helps you in pinpointing the diagnosis, and then it also becomes easy for you to manage those conditions. So let's talk about that algorithm. Okay, so let's talk about that sore throat algorithm and the initial approach to a patient, pediatric patient who has got sore throat. So if you look here, if you look at the algorithm right over here, the first thing to note is if the child seems to be acutely ill. Does the child seem to be acutely unwell? If the child is acutely unwell, then you have to consider the life-threatening conditions of sore throat, namely epiglottitis, retropharyngeal abscess, lateral pharyngeal abscesses, tonsillar hypertrophy secondary to an Epstein-Barr virus infection, diphtheria, and Limeri syndrome. So the differential diagnosis is big. But again, some of the relative symptoms and signs would give you an idea. For example, a child who has got drooling and looks unwell and has got stridor would be having epiglottitis. A child who has got difficulty in swallowing and has got stridor might be having retropharyngeal abscess. A child whose monospot test is positive, or let's say who had antibiotics in the past and has gone worse rather than improving, you would be thinking on Epstein-Barr virus infection. A child who is severely unwell, who had multiple doses of antibiotics and is not improving and looks very unwell, maybe with pain in the jugular veins, you would be thinking of Limeri syndrome. So the first thing in an approach to sore throat is to see if the child is acutely ill or not. So if the child is acutely ill, then you have to consider the all those causes which can be life-threatening for sore throat. Then if the child looks relatively well, then you have to see whether the tonsils are unilaterally enlarged and crossing the midline or not. So you have to open the mouth and look at the tonsil. If one tonsil is bigger than the other and is crossing the midline. So if one tonsil is bigger than the other one and crossing the midline, you think of what? Peritonsillar abscess. If both tonsils are equally enlarged, you will see if there are any buccal or gingival lesions, so if there are any lesions on the mouth, on the gums, or on the tongue. So if the lesions are present on the mouth, like around the mouth, on the gums, on the tongue, on the buccal mucosa, then you have to see whether it is a multi-system disorder or not. Multi-system disorder means, are the joints involved? Is the skin involved? Are there any other organs involved? So if the other organs are involved, then you would see whether they have got cyclical fever or not. So whether they are having like fever every few days with it or not. So if they are having few like cycles of fever with it, we actually diagnose at, we call it as P-PAPA syndrome, which is actually periodic fever with epistomatitis, pharyngitis, and adenitis. If no, then you would be thinking of Stevens-Johnson syndrome, Behçet syndrome, or Kawasaki disease. If they do not have multi-system disorder and they just have got oral lesions along with a sore throat, you would be thinking of herpetic stomatitis, or you might think of herpangina, which are caused by herpes simplex virus and Coxsackie virus respectively. If there are no buccal and gingival lesions and the tonsillar hypertrophy, tonsil inflammation is equal on both sides, you would see whether there is any foreign body embedded in the tonsils or not. So if there is foreign body, obviously their history would also be suggestive of that. You would diagnose foreign body as a cause of sore throat. If not, then you have to see whether the pharynx or the posterior pharyngeal wall is inflamed or not. If it is inflamed, you would diagnose this as infectious pharyngitis. If not, still the infectious pharyngitis could be a reason for sore throat, along with pyogenic psychogenic pharyngitis, which is caused by repetitive clearing of sensation to clear the throat, or it could be a referred pain because of the inflammation in other structures like middle ear cavity, like a dental abscess. But if it's infectious pharyngitis, you know it's either viral or it's bacterial. Again, if it is full of exudates or something, you would treat it as a streptococcal bacterial pharyngitis. If not, you would treat it as a viral pharyngitis. Remember, as far as treatment is concerned, if you are treating it as a viral pharyngitis, you don't need to give them any treatment except symptomatic treatment. So you can give them painkillers like ibuprofen and paracetamol for pain control and controlling the discomfort, or you can give them benzidamine 0.5% throat spray. So they usually spray a couple of times in their mouth, usually 4 to 6 hourly, and the number of sprays is based on their weight. So I think for every 4 kg, 1 spray. So they can do like, maximum of 4 sprays every 4 hours for 3 to 5 days. And if it is bacterial pharyngitis, remember, Group A streptococci, you have to give them narrow spectrum antibiotics, and phenoxymethyl penicillin for 10 days is the drug of choice if you are giving them oral treatment for pharyngitis. So this algorithm, if you see, it makes it easy for you to narrow down the causes of sore throat, and then at the same time, once you have diagnosed, it's easy for you to treat them as well. So I hope you have liked this short talk on pediatric sore throat, which help you in making a diagnosis and knowing the causes, different causes of sore throat in the pediatric age group. And if you haven't subscribed to my channel, please do subscribe, and always press the bell notification icon so you know whenever I upload a new video. Thank you very much for watching. Bye-bye.